Tonight's discussion is on back pain management in general practice. It's a very common problem that we encounter in our practices. I'd like to thank Mandy from MIA for organising these radiological clinical discussions. They're excellent. We have two excellent speakers tonight, Dr. Andrew Rothstein, a radiologist at Victoria House with special interest in musculoskeletal radiology and musculoskeletal and spinal injections. We have Dr. Tim March, who works at Eastbound Clinic at Langwarrin and Frankston, specialising in sports medicine, and Tim has a special interest in back problems. And I'll ask Tim and Andrew to get the show underway. Thank you.
Okay. Thank you, Patrick, for that introduction. So I'm Dr. Andrew Rothstein. I'm at Victoria House Medical Imaging in Paran, and as Patrick said, I've got an interest in musculoskeletal and spinal imaging and intervention. And this is my partner in crime, Dr. Tim March, who's got the clinical component tonight. So just to give you a bit of an overview as to what we're going to cover in this presentation, it's going to be divided up into two components. The first part of the presentation before dinner is going to be more sort of didactic, giving you a background on mechanical back pain, some of the important red flags and clinical features to look for when you take a history and examine your patients. And then I'll give you an overview of the different radiology modalities and what their strengths and weaknesses are. And then the second part, after dinner, we'll move through a series of clinical cases which will augment what we've discussed in the first part. And there'll be the radiology and the management and a bit of a summary at the end.
Thanks very much for having me as well. It's a pleasure to be here. This is a radiological meeting, but there is a paradigm shift from clinical skills to reliance on tests. And whilst I know this is a radiological meeting, I think it's really, really important that we know how to establish the clinical side of back pain. You know, how many times do we see normal X-rays with people with bad backs, and how many times do we see abnormal X-rays and no back pain? There was a study by Ernst in 2005 where a number of symptomless subjects had MRIs performed, and 50% of them had disc bulges. So it's very, very common in the symptom-free patients. And you know, how many of us have seen a postmenopausal woman with low back pain, buttock pain, groin pain, and they've had all the tests. One test has shown disc desiccation in the low back, another test has shown labral tears in the hip, another test has shown gluteal tendinopathy. An MRI might show gluteal tendinopathy, and it might also show trochanteric bursitis or thickening of the bursa. And so what's causing this patient's pain? So it's really important that we understand that radiology is only a supplement to our clinical skills. And hopefully, certainly the more mature group here will have their clinical skills honed. But, you know, there's a, you know, how many times also do we hear from patients? The GP said, oh, it's just a muscle strain in the back. Well, really, muscle strains in the back just very, very rarely happen. We get muscle spasm, we get muscle tightness as a result of a primary disc problem or a primary facet joint problem. 80% of back problems that would occur would be injuries of the facet joint or the discs. And then they might have secondary muscle spasm. You can treat that secondary muscle spasm with massage or acupuncture or various other techniques. But it's not usually a primary muscle problem. So what I'm going to try and do is to show the clinical features, both on history and examination, of facet joint problems, disc problems. We'll go briefly through other things like SIJ, pars defects. We're going to have a quick look at trochanteric bursitis and gluteal tendinopathy, which is a common problem that we see in general practice. We're going to look at the difference between mechanical back pain and non-mechanical back pain, and that's really important when we come into red flags. You know, we have to establish whether pain is aggravated by movement or aggravated by certain mechanical things. And referred and radicular pain, well, does the pain go below the knee? What's the nature of it? What are the clinical examination features? So as far as red flags are concerned, we all know these, but just to remind you, increasing age, history of cancer, fever, trauma, drug dependence, immunosuppression, night pain, that's pretty important, although a lot of people get night pain with mechanical back pain as well, because like all soft tissue problems, the pain usually improves with warmth. So as we warm up, we don't have the problem. So we might do some gardening, and 2 days later, or that night, or the next night, we'll have ache in the back. And we turn over in bed, because we've cooled down, it wakes us up. So it's not that sort of mechanical night pain. We've got to distinguish between the difference between mechanical night pain and non-mechanical night pain. Bladder and bowel problems, neurological deficit, etc. So as far as anatomy is concerned, I don't want to go into it in great depth, but I just want to remind you of a few things which will help us hopefully distinguish between facet and disc issues. When we stand, the spine is an S shape, like that. So we have a curve, a lordosis in the neck, we have a lordosis in the back. And the spinal column is actually in the middle of the body. You can operate as easily on a disc from the front, well, with the exception of a few minor vessels on the way, as you can from the back. And it has to be like that because it's the center of gravity of the body. When people come and watch, I work with some spinal surgeons, when people come and watch spinal surgery, the first thing they notice is, gosh, what a long way down it is. But you go through skin and fat and muscle, you move the muscle down, and then you get to the joints, and the joints are 2 inches down, Andrew will be, as I do, using 2-inch, 3-inch needles, spinal needles, to get down to these joints. It's a long way down. And so it makes you wonder sometimes, what physios are doing when they're doing sort of PA mobs. Are they actually doing anything to the joints? Or are they doing something to the muscles over the top of it or whatever? But the important thing to remember is that you've got this lordosis in the lumbar spine, and each segment, each vertebra, articulates above and below with 3 joints. So there's a disc at the front and 2 facet joints or apophyseal joints at the back. So it's like a series of tripods sitting on top of each other. Yeah. So if you bend forwards, you're going to put stress on the front joint, which is the disc. If you bend backwards, you're going to put stress on the facet joints. So facet joint pain tends to be worse going backwards, extending backwards, or is aggravated going backwards. Whereas disc problems tend to be aggravated bending forwards. But of course, we must remember that it may not hurt while you're actually doing these things because you're warm quite often. When you're playing sport or you're working out in the garden, it's warm. It's only when you bend over and you're cool. You just got up from sitting down and you bend over and you're cool, and then suddenly you might feel pain. That's because you're cool. So trying to distinguish between facet and disc pathology is pretty important because that's about 80% of your low back presentation in general practice. So you know the anatomy. Is it worse bending forwards, bending backwards? Is it insidious or is it an acute onset? By acute, I don't mean less than 3 months. I mean, is it sudden? Like, did you bend forwards and turn over and then you can't straighten up? That's an acute onset type problem that's much more likely to be facet joints. Past history, have there been recurrent episodes? There could be a history of someone presenting twice a year with sudden onset back pain, and they will improve slowly over 2 or 3 weeks, or they might go and see an osteopath or a chiropractor and have a manipulation or a treatment, and that treatment might shorten the episode, or they might come see me and I might do other things. I might do facet joint injections or muscle injections of local anaesthetic or whatever. And that history is important. Or did it did they do some gardening and then 2 days later they had a problem? Sometimes you can't tie the things, is it a long car journey, 2 days later, and then they bent over and picked something up and then they felt a twinge, but their back pain came on gradually. It's much more likely to be disky. Aggravating factors, if it's worse, bending or sitting, tends to be more disky. Relieving factors, and the opposite for facet joints, of course, standing would aggravate it, and arching backwards would aggravate it. Relieving factors, red and yellow flags. So we've gone through red flags. Yellow flags, of course, work cover and TAC and so on. Are there any incentives for people not to get better? Certainly, there have been studies which have shown the fact the earlier you do MRI scans in some of these industrial problems, the worse their prognosis is. So facet joint problems are up to about 40% of low back pain. They're acute in onset, so often sudden in onset, although, down the track, if they've been manipulated and seen chiropractors and osteopaths and so on, then it can become more confusing. It often resolves in 2 or 3 weeks if you do nothing. It's often a bending and twisting mechanism, so you bend and twist. So if you can coach them not to bend and twist, if it's their left facet joint, it's usually them bending forwards and twisting to the right, and the facet joint opens. And there are meniscal bodies within the facet joint, a bit like within the knee, and those can flip in and out, or a bit of capsule can get stuck in the facet joint, and then they try and straighten up, and bang, and the muscles clamp up, and they can't move. And for those patients, I often actually inject their muscles with local anaesthetic when they come in and see me, and that relieves all their muscle spasm, and then I gradually get them moving, and I sometimes can manipulate them out. Or if you can teach them to do a specific exercise, then you can treat them quickly. They're worse standing than sitting, because when they're standing, they're extended backwards. Sitting, they're bent forwards. I'll demonstrate that soon. They have pain which sometimes refers, diffuse pain, but it's not radicular pain. It's not like sciatica. It's a sort of diffuse pain that can radiate to the buttock or sometimes the thighs. Sometimes it goes below the knee, but very rarely does it go below the knee. And if it goes below the knee, it's only ever upper calf. It never goes down as a hot wire. I mean, you can have a rotation in the spine, which can affect both the facet joint and disc, and you can get discs and facet joints problems together. And if you get that rotation, then sometimes that can cause sciatic type pain because the nerve is caught in the foramina as it's rotated. And they tend to have asymmetrical movement patterns, or what we call partial articular signs. So, going backwards, they might be painful. Going to the side, to the left, if it's a right-sided problem, they're not painful. If they go to the right, that way, then they might be painful because they're compressing the facet joint. If they go backwards and to the right, then they're painful, and that causes low back pain, maybe with some slight diffuse referral into the buttock and thigh area. Disc injuries, in contrast, insidious in onset. So often the predisposing problem occurs, and then a day or two later they might have those symptoms which gradually come on. They might wake up in the morning and hardly be able to move 2 days later. The aggravating factors tend to be bending, sitting. They're worse sitting than standing. And they're aggravated by things like lifting and coughing and sneezing, putting on their shoes and socks. That 30-degree bend, that 30-degree bend, that's when, the disc pressure is quite high. And they certainly can get significant back pain then. And they can get referred pain as well, which can be very similar to facet joint pain, but they also can get radicular pain as a result of the disc gradually impinging on nerves and causing pain below the knee and sometimes down into the foot. They're more likely to be associated with a list, but that's not an absolute. And disc problems tend to occur in the middle age. That's good news for some of us oldies, because we dry out as we get older. We're like flowers. Flowers, a little flower can come up and they're bendy, and then they get bigger, and you can half break them, and then they get up to an old tree, and you can break them, and the twig is brittle. And we're like that. We dry out with age. And the discs dry out with age, and as the discs dry out, they become more stable. So in fact, a lot of people get disc problems in their mid-age, 35 to 45, 50, that sort of age. When they get to 55 and 60, they tend to get less disc problems. It doesn't mean to say they don't get disc problems, but they tend to get less. And it's certainly not a soft type of disc problem. This is just to remind you of the pressure of the disc. This is a study which was done on volunteer medical students, putting pressure manometers in their discs at L3-4. It's very kind of them. And I think they got paid. Whoops. And you can see that by bending forwards, the disc pressure increases, and sitting down, the disc pressure increases even more. And if you add a weight, it increases. And in fact, they measured it not only lying down, but also extending. The disc is opened and the pressure is reduced as well. So hence the rationale for extension type exercises. So examination. So I would need Sean for this. So I've already taken a history, so I have a fair idea of whether it's going to be a facet or discy problem. But so if they've got extension pain, I might be a bit careful, a bit ginger about extending them back. And if it sort of feels like a facet joint issue, if they've got a discy problem, I might be a bit ginger about bending them forwards too much, because I might aggravate them. And how many of us hear about work cover doctors, examining a patient? Oh, it's much worse after I've been examined by that doctor. So I think we have to be sensitive to the patient. So I'll get you to just arch your back backwards, and normally you get about a 30-degree bend. Is that painful? Is that your pain, or is it a different pain? It's very important to know that. Where's the pain felt? Is it on the right side or the left side? Is it a facet joint problem? You can usually work that out. And examine to the right. Is that causing you pain? If that is, it's likely to be a right-sided facet joint. Could be right-sided disc as well, but it could be right-sided, and it could be left-sided disc as well, which I won't go into that. And then we go left, and then I usually examine what we call a quadrant test. So we go backwards and to the right. Now, two reasons for that. The first is it compresses the lower right facet joints significantly at that point and can cause pain. And so that's in their back, maybe with a bit of diffuse referred pain, but not radicular pain. But secondly, if they've got a foraminal disc, so it's a disc in the foramina, so that it's closing on the nerve, or if they've got canal stenosis in the foramina, so there's canal stenosis, which is central canal stenosis, and there's foraminal stenosis, which is on the side, then that can bring on pain. So if they're presenting with leg pain going down below the knee, and I think this is sciatic type pain, I will want to know whether this induces their leg pain. That's really important, because you don't want to be giving them extension exercises, Mackenzie extension exercises, because that'll aggravate them. I've seen it so many times with physios who's madly going with extension exercise. It makes the patient worse with canal stenosis, makes the patient worse with foraminal stenosis, and makes the patient worse with facet joint problems. And then going backwards to the left as well, same thing on the other side. And then bending forwards, touching your toes, and up again. And I will obviously look for scoliosis. I will do other biomechanical things, looking at leg length and that sort of thing. And at this time, if they've got leg pain, I'll look for nerve root signs. Can you hold my hands? Can you go, stand on so your right leg is the one that's symptomatic. So if you can stand on your right leg and you go up on your toes. No, with the one leg. Oh. So go up and up and down. And is that weak? We can compare it with the other side to see if they've got any S1 signs. It's really, you can't tell when people are lying down flat whether they've got S1 calf weakness or not. You have to do it standing up. Next thing I do is get them sitting. And at this point, I'll do what we call a slump test. So I'm sure most of you know what a slump test is, but if you don't, nerves move. If I bring my head forwards, that brings my brain forward. It pulls up my spinal cord. They've done these studies on cadavers. They've done them, with MRIs. And if I get someone to bring their leg up, the sciatic nerve is then stretched and the nerve comes down. If the nerve is being caught by a bit of a disc or foraminal stenosis or something like that, then it can cause pain, and that nerve is stuck. So just pop that down. So I'll get them to, if you can drop your head down, if you slump your body down, does that bring on any pain? No. Right leg pain. So we'll lift this up. Is that causing you pain? Yes. Is that the same pain? Yes. Or does it go down to your big toe, L5, sorry, or down to the lateral side, pins and needles, S1. And then if you can lift your head up, does that relieve your pain? Yes, jolly good. If it doesn't relieve your pain, then bring your head down again, and we'll just reach this down a bit until your pain's almost gone, and then we'll lift up, and we can alternate movement of the head and the leg to see if we can bring on sciatic or radicular pain. At the same time, how are we doing time-wise? I think we're okay. Yep. Measure reflexes. I find that reflexes are more easily measured or performed sitting. And then I'll get you lying down. Normally we'd have the shoes off. So straight leg raise, measuring for when, is that your pain? Yes, that's your pain. So you measure the degrees, and obviously if you bend it up, then the pain's going to go. Same with the left side. I would probably measure. At this stage I would do check the hips. I would check hip in rotation, in flexion, adduction, and then at the same time I would check for sacroiliac joint problems. Sacroiliac joint problems occur in about 20% of people with back pain. So there's the fade test, which is pushing down here. If that's positive, I get them to support their back. So if you support your back, and if it's no longer positive, then it's more likely referred from the back. And then there's the Faber test, which is flexion, abduction, external rotation. And that can be positive for sacroiliac joint problems and also for gluteal tendinopathy, because you're actually in that position, you're increasing the tightness of the gluteal tendons. And then the spring test, which is crossing your hands across like this. And then if you can go on your side, and then you can spring the sacroiliac joint that way. And there's another test which is called a Gainsler test. So if you can go that side, right, and we'll drop your symptomatic side down. So let's say it's the left side, and lift this up. And if you can hold that with your hands and pull that apart, and you separate that, is that bringing on your pain? And then that's another test for sacroiliac joint dysfunction. Okay, back again. At this point, I would measure power. So if you pull your feet up, testing for tibant, and then the big toes for EHL, extensor hallucis longus, and peronei. So push your foot to the left against me, and this foot to the right against me. And then I would test sensation. I won't tell you how to do that. And then if you can lie on your stomach. And at this point, I would, if it's sort of thigh pain and knee pain, having examined their knee to make sure they don't have any pain with flexion of the knee, then is that bringing on your thigh pain, that's a positive femoral stretch test. You can actually pull the knee backwards a little bit more to actually increase that. And you compare it from side to side, and if there's a difference, that's significant. Then I palpate the back. And I usually draw on the back and work out where the joints are and roughly where the tenderness is, and that gives me a more complete picture. So that's my sort of quick examination. So thank you very much for that. That's great. Okay, so with facet joint injury, this is treatment of facet joints. Education with all of these sort of things is incredibly important. It's avoidance of the mechanism that brings it on. So that's the flexion, twisting type thing. So like, for instance, I had a bus driver who every time he turned around to make sure the kids, the school bus, were coming, his back would go out. And so if you coach him to extend his spine before he twists, it doesn't cause the problem, because as you bend forwards, you open up the facet joints at that level. And repetitive extension, some physio has been going mad at doing extension exercises that can sometimes bring it on. Exercises. So as far as exercises are concerned with facet joints, the best way to open up your facet joints is knees to the chest. So one knee, other knee, both knees, so rocking, and then rotations. Now rotations, it's really important that you don't just rotate like that or like that. You have to actually pull the knee right up and hold it up in 90 degrees in order to open up the facet joints and allow that to go over. So that's rotating and opening up the left lower facet joints, and the same the other side. Anti-inflammatories, maybe cortisone tablets, reducing cortisone. A lot of GPs do that, and that works quite well from time to time. Manipulation. Would you like me to show you quick manipulation, Sean? Would you like me to show you just how one manipulates the lumbar spine, the $1 million roll, or have you all seen it? Yes? Okay. So just quickly. So it's important to flex up the lower spine, so bend your knees. So we start off by loosening up the spine, like that. And then lay the bottom leg down, top leg up. You can feel the lumbar spine as you lift the top leg up, and you can feel when let's say it's the bottom leg at L5S1, the bottom joint at L5S1, because you palpated it there and that's where it feels. And then it's important to get in the right position. So rotate the upper spine, and if you can hold your elbows. I don't know whether you can see at this point, but my right arm goes here, my left arm goes there, and there's a twist, and you take a deep breath in, and as you breathe out, I just put a bit of overpressure there, and then boom. And that's the $1 million roll. Chiropractors and osteopaths, eat your heart out. Okay, thank you. And it's actually quite easy to do if you've practiced it a lot, but you don't want to use too much pressure. It's got to be done in a relaxed way. And sometimes when they're acute, as I say, I do lots of massage and maybe even an injection into the muscles, because that'll loosen off the back, and then you can manipulate them, and then they're fine. And if they can manipulate themselves, they can sometimes self-treat. Facet joint cortisone, when acute, sometimes I do those in my rooms because it's much easier than getting CT SPECT or other investigations and then organising it under CT. That takes a few days to actually organise. This you can do acute, and I do a lot of those sort of injections for acute patients. And then there's CT-guided cortisone. So, Andrew. We'll just go into, just before we go to CT-guided injection, radiofrequency. You've all heard of radiofrequency. This is for chronic facet joint pain. You do medial branch blocks, so the medial branch of the posterior primary ramus is the innervation to the facet joint, and you can use a radiofrequency probe to burn the nerve going to the joint, and that can reduce pain for about a year. And in my experience, it works well the first time, and then over time it works less well. So I try not to commit patients to that unless there's no other option. And surgical fusion, I certainly wouldn't recommend that for facet joint pain.
Okay. So this is an example here of a CT-guided facet joint injection that I've done. So the patients all get consented. There's a small risk of bleeding and infection. We mark a spot on their skin with the patient prone, and then I guide the needle down. I give some local anaesthetic, and then I guide the needle down into the facet joint. You can see here are the two bones making the joint, and here's the joint in here, and we make sure that the needle's in position. Sometimes we get it first go, sometimes we have to adjust the needle and take some scans, and then I inject in some steroid and anaesthetic into that joint. It's a small joint, only contains a volume of say 1.5 mils, and then I give the patient a pain chart which they can document, and then we're interested in what the response is more with the anaesthetic in the short term, but also long term, and they can give that back to the clinician.
Me again, sorry about that. So disc injury is slightly different. Obviously they have to avoid bending, lifting, prolonged sitting. If you're brushing your teeth, hand on the sink, brush your teeth, toothbrush down, grab a glass of water. There's no good doing this. That's 30-degree bend. That's going to aggravate their disc problem. Sit in a standing posture. Can you all stand up? I want to demonstrate one thing to you. So if you can all stand up, just feel the back of your spine. You can feel the lumbar spine here, and it goes out to your buttocks and goes in at this point. So if you go backwards, that increases the lumbar lordosis, doesn't it? And as you go forwards, it decreases lumbar lordosis. So you want to be extended for disc problems, generally. That's if they don't have no extension pain on examination. So while you're feeling that, just sit down and see what happens to that. Does it go out? It does, doesn't it? And then if you stand up again, it's obvious that it's extended. So the standing posture is a better posture for disc problems if they've got no extension pain. So they're better off sitting on high chairs like stools, or sitting on footballs or saddle chairs or kneeling chairs, or if they're sitting on a chair like this, try this. I don't know whether you can see this from the camera, but sitting on the edge of the chair and dropping one leg down, pointed at the floor. So if you try that, your lumbar spine goes in, and that is a comfortable position for people with disc problems to sit. So if they're sitting at a table like this, they're much more comfortable, and you can swap legs.
Is that where the idea of those chairs years ago where you used to sort of
Kneel, yeah, they're called balance chairs, and the same sort of thing. It's trying to open up this angle in order to be able to extend the spine. And if they're watching television at night, just lie down. Lie down. That's a good posture for a disc problem. Just pad up your back with some pillows. But 5 minutes, right? Okay. Mackenzie proprioceptive taping. I won't do that to you, Sean. But anyway, it's taping which runs down the back to try and prevent movements forwards, and it's to make you more aware of bending forwards. Mackenzie exercises. Everyone knows what Mackenzie exercises are? I'll just demonstrate it quickly if you don't. So it's lying on your stomach. There's lots of different types of Mackenzie exercises, but the basic extension, is you've got to relax your back, let your buttocks relax, and it's a passive sag, and it mustn't be painful. You mustn't push through pain. And you hold that up for 5 or 10 seconds, and then back down again, and do the same thing, and you do 10 of those.
I'm going to need some of those 5 minutes as well there.
Okay, all right. Just quickly, massage, acupuncture, Nesfield treatments. I do Nesfield treatments. These are treatments for muscle spasm secondary to facet or disc problems.
I'll just move on now, just a little bit of time just in this introduction, first half, just to talk about radiology components. Everyone gets worried about radiation exposure, so just to give you, this is a nice table showing that everyone gets 2 millisieverts of background radiation. We all get that each year without having any radiology done to us, and just shows the scale here increasing from lumbar spine to bone scan to CT. When we do a CT injection, there is a small radiation dose as well. But importantly, at the bottom here, you can see MRI of the spine has no radiation. So MRI, if you've got one message to take home, MRI, there's no radiation, so there's no harm to the patient as far as the imaging technology. Xray, we still use Xray. Xray gives us a great overview of the spine, especially if the patient's erect, so we can see is there a scoliosis. Also helps us look for the red flags. So if we're concerned about tumour or fracture, gives us a good overview of degeneration. We can do functional X-rays with extension and flexion, looking for a slip, looking for spondylolisthesis or retroliesthesis. PARS can be seen with oblique X-rays, but I'll touch later on in this talk that MRI has sort of superseded that to pick up the important PARS stress fractures, and as I've said, scoliosis. Bone scan, what is bone scan? We're injecting a tracer which shows osteoblastic activity, new bone being laid down. It's a very sensitive test. We can do, as you can see here on the left, a planar image, which is like an X-ray, or we can now do SPECT, which is like a CT of a CT bone scan, which gives us more anatomic information. There still is a radiation dose, and it's a functional test. We still don't get enough anatomic information. So we often need to go on and do CT or MRI to work out where the hot spot is, why the hot spot's hot. So you can see there's a hot spot in this area, but we're not sure, is it the facet joint, is it the PARS, what's occurring? So we've now got the ability to take the CT scan and the SPECT nuclear medicine and fuse them together to produce this sort of psychedelic colour where you can see this is where the hot spot is. So then we're able to say that the activity is from the facet joint. Now this is especially important in elderly patients who may have a lot of degenerative facet joints, which we'll be able to see on the CT, but we won't know which one is symptomatic, especially if we can't work out the anatomy from the surface anatomy. But by fusing that with the bone scan, we can give anatomic information, and then we'll know which facet joint is symptomatic, which facet joint we may inject. CT is really just reserved for bony information. So to look at the facet joints in the setting of trauma, to look for a fracture, I use CT to guide all spinal intervention. But the real issue is, unfortunately, out in the community, we are still doing CT of the lumbar spine, and that's really because of the financial thing, the fact that there is a Medicare rebate available for CT but not for MRI. And CT, there's more CT machines around town than MRI machines, so patients can get in quicker. But the cost for MRI is unrebated MRI is very cheap in Australia compared to, say, New Zealand or other parts of the world, and it's really only $305. So ideally, in the patient's best interest, we should be doing MRI, so there's no radiation, we get better contrast resolution. We're also able to pick up some of those red flag conditions. MRI, it's the best one test, provides an excellent overview, and that's because of this contrast resolution. There's no radiation. You may have heard of T1 and T2. The T2 is the fluid-weighted sequence. The CSF is bright. The problem with MRI is often that it's too sensitive. So we're able to pick up lots of pathologies in different locations, but we need to correlate that back clinically. I'll show you an example of why MRI is better than CT. Here's a CT showing a large disc extrusion, which is hard to see, but then the same patient with the MRI, you can see here's the disc, while here it is on the CT. So it's just this ability to differentiate CSF from disc helps us. Here's also on the CT, sagittal image, here's a T2 and a T1. So as Tim has alluded to, discs are very common, and we know that if we image asymptomatic patients, this was a study showing 28% would have a disc lesion, but they are increased in symptomatic patients. The aim of MRI is really to work out, one, the level, so which specific level is causing the problem, and two, what lesions are acute or symptomatic versus what are chronic. And the way we do that is we look at the signal on MRI. So we know that with any pathology, edema is, an acute thing will be bright, will have edema, will have fluid, while when it becomes chronic or becomes elderly, it becomes dark, it loses fluid. So here's an example of an acute disc protrusion on MRI. It's ill-defined, it's hyper-intense, versus the chronic extrusion. You can see it's very sharply defined, it's dark. We know that with discs, eventually they shrink down over time, as this study has shown, and that surgery is based clinically not on the size of the disc. Well, maybe we'll take one or two questions, but we're going to serve dinner, and then in the second part we're going to go through some cases which will illustrate our relationship and also discuss clinical and radiological impact.
Thank you. Quick question, when you're talking about the acute versus chronic,
yes.
How long does it take to become chronic, the change turn into chronic? So usually you wait for a while before you do an MRI.
I would say, look, it's a gradual process. I would probably say maybe at 3 months it would start to look like those darker cases, but I think in that 0 to 3 month period it would still look ill-defined, hyper-intense. The fat will be a bit poorly defined, consistent with an acute inflammatory process. And the idea is then that we take the clinical information you guys have given us and then we correlate that to the MRI to suggest which is the most likely disc lesion, because that has then implications for any intervention that's done. Yes?
Actually, my
Question for Tim?
Tim. Tim, you said sciatica below the knee. Don't you see L1 and L2 sciatica? I do.
Yeah. Sorry, I was saying that it's unusual for referred pain to go below the knee, but it's not unusual for sciatica. And of course, 90% of disc herniations occur at L4-5 and L5-S1, and so it tends to go below the knee. But of course, L1-2, L3-4, they're L3-4 classical in an older golfer, a 60-year-old golfer, and they get thigh pain. That doesn't go below the knee, so it depends on the level.
And with Andrew, I haven't seen any double-blind controlled studies with injecting the spine or facet joints versus the placebo effect. Are there trials which show the effectiveness?
Yeah, I think we've got coming up, there are some articles that show benefit. So I think, I can't quote them off the top of my head, but I think there is some stuff in the second part that shows the benefit of these procedures. Plus, anecdotally, I know anyway, in my personal case series, I think there have been patients that have had benefit, and I think Tim will back me up on that as well.
Yeah, there are studies, but I've got them written down in my case, but I'd have to look for them.
Yes. Yeah. We'll touch on that in the second part.